Good morning, everyone. Welcome back. It is Tuesday, November 17th, and we have a phenomenal panel today of health policy experts. We're thrilled to have them. I think this session couldn't be more timely in terms of the conversations that we need to be having right now, particularly in this moment with the pandemic. And we're so lucky at Harvard to have really one of the best health policy programs in the country. And these four experts who are going to be joining us today really represent the best of that. So we're thrilled to have them. I'll just do a few updates before I pass it over to Alan today. So, again, as many of you have seen, it's a sobering time in the pandemic. Rates are continuing to rise across the country, probably in many of the places where you all are right now. And there is, of course, Thanksgiving on the horizon and anticipated travel associated with that. Unfortunately, yesterday there was a new record for hospitalizations in this country. So again, an important reminder for us just to be safe and follow guidelines of public health officials. I will say there is also some good news on the horizon with new data coming out about the vaccine from Moderna yesterday to add to the information, excuse me, from Pfizer, their positive findings last week. And so I think this offers us a wonderful opportunity to reflect on some of the incredible science. And you heard from Professor Lindsay Baden, who has been really one of the leaders here at Harvard in terms of leading the Moderna trial. And both the vaccine coming from Moderna and from Pfizer are what are called mRNA vaccines. They're a new type of vaccine that hasn't been used for COVID or certainly fighting any other viruses. And so I think it's an exciting time to see some of the new science and technology that's being put out there. There's also a lot of issues that we have to confront about distribution. And I think some of our speakers today are really going to touch upon some of the critical questions that we think about around how does the pandemic impact and threaten our health system in general. And I think a lot of the interface now as we think about distribution of a vaccine like this and how we're going to be moving forward, it's really critical to be thinking about the health systems that are in place, particularly in rural and low-income communities. And what are some of the long-term implications that we can be thinking about for the healthcare that we are delivering in this country? So we really are thrilled to have these four experts today, and I'm going to pass the baton to Alan to introduce them right now.
Thanks, Ingrid. I know all four of today's speakers pretty well, and I'm incredibly proud that they all earned their PhDs in the Harvard PhD program in health policy, which is a really unusual program. So I just wanted to quickly tell all of you about it. It's a program that's about 30 years old now, and it was set up with the idea that no particular department could cover all the areas of health policy. So it drew together all of the Harvard faculties to help educate advanced students who wanted to work on critical questions of health policy, which are, as you know, so diverse. And all of these people actually went through that program and have joined and excelled on the Harvard faculty. I have to say, as a longtime teacher in that program, and I was around when it began, I'm just so proud to see the development of the group that we've gathered today and the really important contributions to knowledge that they've made in fundamental areas across the health policy domain. So I want to welcome you all here. Our first speaker today will be Dr. Benjamin Sommers. Dr. Sommers is a professor at the Harvard Chan School of Public Health in their health policy unit and at the Brigham and Women's Hospital, where he's an active clinician. He's worked a lot on fundamental issues of health economics and policy, especially relating to access to care, the healthcare safety net, vulnerable populations. And like all of our speakers today, it's not surprising, all of them have turned their attention to one degree or another to the pandemic. And I think we've seen that among so many of our speakers during this term. Our second speaker will be Professor Sara Bleich. She's a professor also at the Harvard Chan School, and she's also a professor at the Radcliffe Institute for Advanced Study. And that's not a place that every undergraduate necessarily has contact with, but it's a remarkable research institute that brings together fellows from all around the world every year to work on critical problems. And she has a senior role there and an appointment at the Radcliffe Institute. Our third speaker will be Dr. Zirui, who many years ago, as an early PhD student, assisted me in work that I was doing in a really remarkable way. But he's gone on to become a leading person in thinking about issues of payment, quality of care, health systems, and health policy. And it's really wonderful to have you here to speak about some of the things you've been thinking about the pandemic. And our fourth speaker is Professor Haiden Huskamp, who is a member of the Harvard Medical School's healthcare policy department and a leading figure in thinking about policies, especially relating to issues of mental health and substance abuse, and has recently been thinking a lot about the role that telemedicine has played in treating both substance abuse and mental health problems. And it's fantastic to welcome Professor Huskamp. Let's turn to Professor Bleich. I forgot to mention when I introduced her that she's one of the foremost experts on food, diet, and health, and especially in the relationship to vulnerable populations. And obviously the pandemic is having a major impact on issues of food security. So Professor Bleich, thanks so much.
Thank you, Alan. The slides are visible?
Yes.
Great. Well, it's great to be with you all. And so what I want to talk a little bit about is first the problem of food insecurity, just to underline how significant it is right now, talk about what has happened through legislation in the past several months, and then where we need a lot more activity. And some of that's going to complement the comments that you heard from Professor Sommers. So just to give you a sense of food insecurity, it refers to, sorry, I did move these Zoom boxes. It refers to lack of adequate access to healthy and affordable food. And what you're looking at here is just trends of food insecurity over more than a decade, almost 20 years. And on the vertical, you have households that have food insecurity. And then on the horizontal, you have time. And so the take home point here is that, sorry, these are jumping around a little bit, is that food insecurity was going down pre-COVID. And what we also saw is that there were really big disparities also pre-COVID. And so the top lines are representing Black and Hispanic households in orange and blue. And then the bottom lines, you have overall in Black and then white households and other Hispanics. So the take home point here is that while we were seeing these promising declines, we were not seeing them universally, and these big gaps persisted. So then COVID happens, and moving into the epidemic, food insecurity affected about 1 out of 10 Americans. Now it's about 1 out of 4, with much higher rates among racial and ethnic minorities. And so you can see here that pre-pandemic, about 1 out of 5 Black households were food insecure. Again, they lack reliable access to affordable food. And now it's 1 out of 3. And so just stop and imagine that thought experiment for a second. Imagine that you simply can't afford food. And so one of the things that's happening, obviously, with this pandemic is there are very high infection rates, there are high death rates, but Black and brown populations are disproportionately impacted in many, many different ways. And one of the ways that's happening is around the ability for families to feed themselves. And so this is something that we've really tried to push on to get it front and center so people are thinking about it in addition to all the economic needs that are really important, and then the healthcare needs as well. And then you can see just among households with children, who we spend a lot of time thinking about, if you just look at the yellow bar for Black households, you can see that pre-pandemic, it was about 1 out of 4 Black households, and now it's 4 out of 10. So the other thing that we know is that lots of Americans live in what are called food deserts. These are areas where you're more likely to experience food insecurity. You live pretty far away from supermarkets and different types of stores. And it was about 19 million people prior to the pandemic. And these are most abundant in minority neighborhoods, which is not going to come as a surprise. And so one of the main frontline federal programs for helping address hunger is the food stamp program. That's what it was formerly called. And now it's called SNAP, which stands for Supplemental Nutrition Assistance Program. Much like Medicaid, this is frontline defense for low-income families, in this case, when it comes to hunger, not when it comes to healthcare in the case of Medicaid. And so prior to the pandemic, it helped about 38 million people afford food each month. And so you get basically an ATM card. You can use it at about 240,000 authorized stores around the country. And the average monthly benefit is about $136 per person. Now, if you break that down by meal, it's about $1.40 per person per meal. So your first reaction, which is probably that's not a lot of money, is correct. It is widely recognized this program is not adequate. It is meant to supplement diets, and people can't, although some do, can't reasonably live on it. Now, this program is designed to be economically responsive, meaning that as the economy shrinks, the program then expands to as people's poverty goes up and they qualify for the program. And then as the economy expands and gets better, the roles shrink over time. And so what we saw from February to May is that there was a 17% increase in SNAP participation because of the economic decline, which was the largest increase in any 3-month period in the history of the program, which means that as of the summer, enrollment was at about 43 million, which is not the high watermark. We hit that during the Great Recession, but it is quite high. So at the same time, Professor Sommers talked about unemployment. And so you can just see here that massive peak that we saw in April where it hit 15%, and it has gone down, which is the positive sign. However, it is not doing so proportionately. So if you just look at September, the top of this slide, it's showing you that the unemployment rate varied a lot by race. It was higher among Black workers, lowest amongst white workers. And if you look at the bottom left, what you can see is that while the percent of all jobs that was lost was about 30%, low wage industries are being hit the hardest. I think one of the things that has stuck with me most is this next slide, which is looking at job recovery. There was a great article that came out in the Washington Post just documenting the massive disparities that are being underlined right now. And so you remember from that graph, like job loss went way up and it's coming back down. However, it is not doing so proportionately. And so recovery is much higher among white Americans compared to Black and Latinx Americans. And the concern is that because there's a concentration of working in low wage industries, working in essential services, that some of these jobs may not come back. And so then getting people back to work then needs to be a priority. So what do we do? This is sort of the big question. Well, the good news is that there has been a lot of policy activity, much of which I'm sure you've heard about in the context of this class. When we think specifically about food insecurity, through the Family First Act and the CARES Act, a number of important things passed. And I'm not going to go through everything on here, but just to underline a few things. One thing that happened through the Family First Act is that if you were in SNAP and you didn't already receive the maximum benefit, which is $680 for a family of 4 in a month, for a temporary period, all families got bumped up to that amount. Now that's a good thing, but it doesn't account for the roughly 40% of families who were already at the maximum benefit. So this boost wasn't able to help them. Another thing that happened is about $16 billion through the CARES Act got pushed into SNAP to anticipate all these surges that folks knew that were coming. And then the third thing, which is really critical, is there is a benefit called pandemic EBT. Now, many of you are well aware that schools have been shut down since about March, middle of March. And for school children that rely on meals in school, which is about 30 million school children on a daily basis, how are they supposed to eat if they no longer have access to breakfast and lunch at school? So pandemic EBT is basically a debit card. Either it goes on your current SNAP card if you're in the program, or if you're not, it's a card for families with children who would otherwise receive meals at school. It's about $114 per child per month. And that originally was through the summer and has now been extended through this entire school year. So there are a lot of important safeguards that have been put in place, but the reality, if you remember back to food insecurity, is it's high and it's growing. And so these stopgaps are not sufficient to help and address all the need right now. And so then what needs to happen? And you heard from Professor Sommers about one of the critical pieces is expanding Medicaid to all states. So I won't say anything else about that. The top left is where I'll just spend a few moments. And so where there's been a huge amount of push in the advocacy community is actually expanding the overall size of the SNAP benefit. This was included in both versions of the House Heroes bill, which passed first in May, in October, and then in October got delayed. And now the expectation is there'll likely be another stimulus in early January, remains to be seen. But the core piece that the nutrition community is pushing for is a 15% boost to the overall size of the SNAP benefit, which is equivalent to about $100 for a family of 4 each month. And this is something that happened back during the Great Recession. It had a big impact on food insecurity. And so the hope is that even if this is a temporary boost, it can make a big difference for families right now that are struggling. If you think back to all the unemployment right now their families are facing, this sort of boost could make a big difference. And then there are other recommendations here, which we can talk about in the Q&A, or we'll share the slides. I won't say much about this except to underline the fact that during the current administration, there have been a number of policies that are in different phases, which have been designed to reduce participation in SNAP. And so a priority of the nutrition community for the incoming administration is either to reverse or rescind these various policies, which could reduce participation in SNAP by up to 4 million people. And the expectation is these policies will likely be reversed in the coming year. But I think it's important to recognize that, we can't think about these things in a bubble. There are many things that need to happen across the economy if we want to try to lift up the people who are being hurt most. And so key among them is a fiscal stimulus, which will hopefully happen in early January. There need to be efforts to really think about how do we reabsorb all these displaced workers? How do we shrink these very large racial ethnic gaps when it comes to health and education and all the many ways that the disparities that have been longstanding are being exacerbated? And just from a personal perspective, just knowing the number of women that have fallen out of the workforce because of needs to care for children, how does that get addressed meaningfully through policy so you don't have a generation of women then who can't return to the workforce in quick fashion? So I'll just make one point here and then I'll stop, which is as we think about trying to address COVID-19, obviously there are broad needs across the entire US population and frankly across the world. But I think we do have to think about how do we create policies that can most address racial equity, because it is amongst groups that are worse off where the recovery is going to be the slowest. And while there's attention focus now, I think it's important to try to maximize the window of opportunity. So thanks.
Thanks so much, Professor Bleich. This is really incredibly important. The course has centered a lot of attention on racial disparities and the inequalities in a variety of systems and programs and basic health. But it is impressive that these inequalities have affected diet and nutrition so significantly, because obviously one of the concerns we have is that there are the problems of COVID itself, but there are the related circling problems that it impacts that affect health in almost every other area. And obviously nutrition is one of those critical areas for maintaining health, preventing disease, and just any aspect of health measurement. So these are really important findings. We're at such a complicated place in the pandemic because on the one hand, how do you get from here to vaccination? How do you get from here to the next place? And, we've talked about the strategy of flattening the curve, but improving nutrition now seems to be such a crucial aspect of how we will respond to the pandemic. So anyway, I found elements of hopefulness in your presentation. So now let's turn to Dr. Song and get his perspective. Thanks so much.
Thank you, Alan. Wonderful to be here with all of you. Thanks for having me. And it's incredible to be a part of this panel with my amazing senior colleagues. Great. I'll address two questions today. One is the direct healthcare costs associated with treating patients with COVID, and expanding from that, what COVID might cost our nation more broadly in both the economy and the health of the population. And then second, I'll address the implications of the pandemic on providers with a focus on primary care physicians, given the request of the course. And so this simple diagram is meant to illustrate that the care of our patients with COVID here in the hospital and in our clinics certainly paramount to our approach to this pandemic. But more broadly, from a societal standpoint, healthcare spending and the financing of practices remains paramount as well. So first, for the actual costs of the pandemic, one thing to look at the beginning is simply the number of cases we've had in the US. Currently, there's an estimated 11.2 million cases out of a country of 330 million people or so, we're roughly at an infection rate totally broadly nationally of 3.4-ish%. And so I'd like you to take that number with you in your mind as we go through some of the forthcoming slides. And this obviously depicts the differences in the first and second and perhaps now third waves that the United States is experiencing relative to its both neighboring and peer countries. So the first piece of evidence I'd like to present is an analysis that my colleague Matt Fiedler at the Brookings Institution and I did a few months ago, trying to look at exactly how much COVID will cost our healthcare economy. And so anytime you want to estimate spending or healthcare costs on something, a disease entity or a population or a set of services, spending has to be the product of the prices of those services times the quantities of those services. So an estimate of spending requires both of these dimensions to be estimated. And on this first table, I'm showing you the prices of the care of patients with COVID. Initially, we have the prices of tests, and those can fluctuate a bit as tests are further refined. We have the prices of office visits, both on the outpatient side and in the emergency room. And we also have, importantly, hospitalizations. The price of a hospitalization in the United States, depending on which payer you're looking at here in the columns, does vary quite a bit. And the nuance here is that hospitalizations for patients with COVID, especially those who require intubation and a ventilator in the ICU, is quite a bit more expensive than hospitalizations without a ventilator. And using data from the past few years to guide us in this respect, you can just get a sense of the magnitudes of the prices per unit, per service for someone with COVID. Now, multiplying this by quantities is a challenging exercise because estimating the quantities of care, both demanded and supplied, requires some assumptions. And essentially the bottom line of what we found was that if we think about the US in two scenarios, one with a low population infection rate, i.e. 5% here on the bottom, and one with a high population infection rate, an example of 60% here at the top, this range in the line segment gives you roughly the proportion of baseline healthcare spending, in other words, pre-COVID total healthcare spending, that's accounted for by direct COVID healthcare spending. In other words, it's the amount of money that we've usually spent on healthcare in our country accounted for by this new spending on direct COVID care, the prices of which was in the last, were in the last slide. And so I noted earlier that we as a country are roughly at a 3.4, 3.5% national infection rate. So we're much closer to the 5% infection rate here than we are to the 60% infection rate here. Obviously 60 remains a possibility and we certainly don't want to get there. But currently, if you look at where we are today, near the 5% population-wide infection rate, the percentage of total healthcare spending accounted for by direct COVID services is rather small. It's essentially less than 1%. And so this has a number of policy implications, especially when health insurers, both private insurers and public, but especially private insurers, when they ask the federal government for further funding to finance how they are doing currently in the pandemic, we generally find that their additional costs for COVID are not so much that it justifies additional financing for insurers at the moment. This is especially true when the amount of care deferred or canceled due to patients staying home has been substantially larger than the 1% number here. Even if we move to a world where obviously we don't want this, the infection rate surges and we get to somewhere around 60%, the proportion of total healthcare spending pre-pandemic accounted for by direct COVID care remains still rather modest. On the median or the sort of best estimate that we've got here, 5.6%, and as high as nearly 10%, but no greater than that. And when we break this down by the insurer type, commercial insurers, largely for people under the age of 65, working patients and their families, for patients on Medicare, largely over the age of 65, and for individuals on Medicaid, which Ben talked about, we can see that roughly the estimates are in line with the total, that at a 5% infection rate, the amount of total healthcare spending pre-pandemic directly going to COVID care is rather modest. When we take that narrow perspective and walk to a broad perspective, the picture really changes. There's a recent article by our senior colleague, David Cutler, and Larry Sommers, who was former president of Harvard, on estimating the total societal cost of COVID pandemic-wide reaching into next year. And here the key is that they are estimating not only lost GDP from unemployment and people losing their jobs, but also the health implications of the pandemic. Premature death, mental illness, mental health, behavioral health impairments, and long-term implications of people with COVID who do not necessarily wean off of their symptoms in the near term and carry those symptoms and potential necessary follow-ups for a longer course. Putting all of that together, you can get as high as a number of 90% of the US GDP attributable to the overall implications of COVID. So this is a much bigger implication, a much broader look at the pandemic relative to the very narrowly defined direct healthcare costs of COVID. So two perspectives there on societal costs. Finally, on providers, I want to first show a picture here of my colleagues at MGH. I'm currently on service now, and the people around me are incredibly skilled and adept and humble in all of the work that they've done over the last 6 or 7 or 8 months. These, in my view, are truly the healthcare heroes on the ground whom we don't have much of an opportunity to give thanks to every day, especially in the public's eye. But from residents to our medical students, to our attendings, our intensivists, our nursing colleagues, our staff colleagues on all of our floors, when the hospital's transformed into more or less a COVID ICU for almost half of the hospital, these were the heroes on the ground doing this work each day. And it's just an incredible evolution of direct patient care to watch. Within hospitals, COVID has certainly had a big effect, but on primary care directly, I want to give you a piece of evidence from a recent survey that I had the privilege of leading with a number of our colleagues across these institutions. And in this particular survey, looking at practices in Massachusetts, what we essentially found was that the lost in-person care, the deferred or canceled in-person visits, was partially made up by this surge in telehealth. And Haiden will talk more about telehealth, but one way to think about this is that as March moved along in 2020, the steep drop-off from the demand shock of patients staying home got us a picture of roughly 60 to 70% of inpatient visits deferred. This is a study from our colleagues here at HMS and elsewhere. The gap between the blue line and the orange line here, the orange being in-person visits, the blue being all types of visits, is telehealth. And so the story is similar nationally and locally, that telemedicine helped a lot. It helped substitute for much of the in-person care that was lost, but it was at best a very partial substitute. From a loss of 200 or so to 115 in-person visits per clinical FTE per month here, we've only had a surge of about 0 to 33 per person per clinical FTE per month telehealth visits, and that's locally in Massachusetts. When we look at primary care practices specifically, the corollary of that overall picture is evident here. In-person visits, again, dropped off. Telehealth visits for primary care was an incomplete substitute. Similarly for medical and surgical specialties, similarly for health systems, similarly for other practices like dentistry and chiropractors and physical therapists. But behavioral health providers were the one specialty who had a near complete substitution of lost in-person visits with gained telehealth visits. In terms of the number of workers affected, what you can see here is that the economic reality faced by many employers was somewhat shared by healthcare providers as well. Staff and physicians and nurses and physicians assistants and nurse practitioners were similarly furloughed and laid off at quite high rates. This comparing pre-COVID in the blue bar, and overlapping the blue is the yellow bar of furloughed or laid off workers of different clinical types. And from a financial perspective, again, revenues from pre-COVID to post-COVID, from the blue to the orange here, shows essentially quite a steep drop-off right as March hit. And the expenses side for primary care, which was always greater than revenues to begin with, and that's a separate story we can discuss at another time, the expenses also dropped because of workers and staff being furloughed in order to save money for practices that keep going. But the difference, the gap between revenues and expenses increased in absolute terms after the pandemic. And so the last piece of evidence here was that we asked practices, without further financial assistance, at least here in Massachusetts, what do you think you'd have to do? And this table compares primary care practices in these two columns, independent, meaning non-hospital affiliated or owned, and non-independent, meaning hospital affiliated or owned, versus all other providers in the state. We essentially see that the most popular responses are, I'd have to cut salaries of my providers or employees, I'd have to cut services or operating expenses, or I'd have to furlough or lay off more colleagues in order to make it. And this is the percent that responded in that way and the percent likelihood on average that they gave to that response. Other responses here for how you'd handle the pandemic going forward are shown with slightly lower proportions of response, but also a non-trivial response in terms of closing the practice, selling the practice, integrating with a hospital or health system. And so this gives you a sense of what practices are facing. And there's been some really good newspaper coverage, including the New York Times recently, as early as this morning, I believe, an article on doctors, especially out in rural and suburban communities, leaving medical practice because of the financial difficulties of sustaining an independent practice during the pandemic. So let me stop there. Again, it's an honor to be a part of this panel. Thank you, Alan, for having me, and I'll turn it over to you.
Thanks so much. This is such fascinating data. And as Dr. Song mentioned, there's an article in today's Times. We can post it on the website that many physicians are just finding it better to retire and stop their practices than continue. And in many ways, it comes back to the mass unemployment question and the impact that the pandemic has had on the economy, because the healthcare economy is such a significant part of our overall economy. So losses there are also having very big impacts. You know, I remember seeing some data early on that, for example, the number of heart attacks being treated had gone down quite significantly early in the pandemic. And it was expected that these were just people delaying, and then the rates of people coming to emergency departments with myocardial infarctions has actually stayed lower than it was before the pandemic began. So the impact of the pandemic on health seeking and its impact on health seems to be, to me, from your findings, one of the crucial areas to be looking at prospectively. And we started the course with my colleague, the historian Charles Rosenberg, and one of the claims that he makes is that every epidemic is a kind of natural experiment, and it stresses all of our systems, and then we see how they respond or what health and healthcare, nutrition are after the assault of a pandemic. And I think all of our talks speak to that already. So I know Professor Huskamp has been thinking about telehealth, and we did a poll early in the course about how many students had actually had a telehealth experience since the onset of the pandemic. And I was impressed that it was nearly 40%, if I remember. So we're eager to hear your thinking on that and other problems that the pandemic has raised, especially in the areas of mental health and substance abuse. So thank you very much.
Excellent. So I'm going to talk about, focus my comments on opioid use disorder before and during the pandemic. So just as some background, nearly 2 million Americans currently suffer from an opioid use disorder. And I know folks in this class are familiar with statistics on the skyrocketing number of opioid overdoses in recent years. Before the pandemic, only about 1 in 5 people with OUD received any treatment. And many of those who didn't receive OUD medications, which are an essential component of evidence-based care for this chronic illness. There are many barriers to treatment, but an important one is the lack of SUD providers, including those with the authority to prescribe OUD medications, which have special restrictions because of their status as controlled substances. And this is especially true, these shortages and the issues they create are especially problematic in rural areas. For the past couple of years, many people have begun focusing and thinking about telemedicine as a way to potentially improve access to OUD care in areas with shortages. However, use rates remain low before COVID, with only a small minority of OUD clinicians using it in advance of the pandemic. But during the pandemic, many of the reimbursement and regulatory barriers that have existed to its use, particularly its use for opioid use disorder, were temporarily removed, And there's been a dramatic shift from in-person visits to telemedicine in general across the healthcare system, as Dr. Song alluded to earlier. So to try to understand the perspectives of clinicians about the shift to telemedicine, last spring we interviewed clinicians who treat opioid use disorder about their experiences and their concerns about the use of telemedicine for OUD care during the pandemic. And their reactions were mixed. Most felt that the transition, which really, basically happened in a matter of a week or two for them. Many of them most of them had not used it at all. And suddenly overnight, most of them were using it. But they felt that the transition had gone much better than they expected. They noted that their patients were grateful to have this opportunity to get care in a way that didn't expose them to the virus. And the clinicians reported that same feeling. But they also noted that the telemedicine had improved access and convenience for their patients who were now able to get their care in the home and not have to get to a clinician's office. And they felt that that could lead to improved engagement and care. And they also noted that their no-show rates had really plummeted because of the pandemic. They also noted some downsides. They told us that telemedicine visits didn't provide the same sense of accountability for their patients, they felt, their patients with substance use disorders. They found with just a video image, from the shoulders up, for example, or even a phone call in some cases, some of these visits were done by phone, that it was harder to observe physical symptoms of withdrawal that normally they would be able to see when they sat across from a patient. They felt that, especially for their newer patients, it was harder to establish rapport. And certainly not all patients could use video technology, which was their preferred way of doing telemedicine relative to the phone. Either patients didn't have internet access, they didn't have an appropriate device, they didn't know how to use it, or they didn't feel comfortable. So this wasn't working for all of their patients. They also told us that they'd made some changes to their treatment patterns during the pandemic. They had been waiving urine toxicology screening for opioids or requiring it less often, since this usually involved dropping off a specimen in person. They were requiring fewer visits. So they may have normally found for a newer patient or a patient who was less stable in their recovery that they wanted to see the patient every week for the first couple of months or every 2 weeks. And they didn't feel comfortable doing that any longer and backed off from that a bit. We also heard over and over that many were hesitant to take new patients, and especially to start them on OUD medications, given what's involved in doing so and the risk they felt in doing that as clinicians, if they could only do it via telemedicine. So once claims data on services used and paid for by insurance were available from health plans, we started an analysis of how care changed in the first 3 months after the pandemic, so March, April, May of this year. Thus far, in comparing utilization rates in March, April, and May of 2020 to those same months in 2019, we've seen the following. So some good news. During the first 3 months, we found no decrease in opioid use disorder prescriptions filled or opioid use disorder related outpatient visits among people who had recently filled a prescription right before the pandemic started. So this is good news. These folks were already somewhat engaged in treatment. They recently filled a prescription, and we didn't see a drop off in their access or utilization for the services that we were in outpatient services. However, some not so good news. Fewer people initiated OUD medication during those early months of the pandemic relative to 2019. We saw about a 25% drop in March, April, and May of 2020 compared to 2019. And this drop is problematic not just for the magnitude between these 2 years, but it was occurring during a time when the burden of opioid use disorder was probably increasing, right? Because of the increased isolation, stress during the pandemic. We've seen early evidence that overdoses have increased during the pandemic. So we saw a drop in new medication starts at a time when need was probably higher. So definitely a concern. We also saw quite a bit less urine testing across all patients, again, around a 25% drop. Finally, during these months, telemedicine accounted for between 1/4 and 1/3 of all OUD related visits by late May, versus only about 0.5% in the first week of March. So telemedicine really sort of stepped in to help ensure access to care, although there was still, the majority of visits were still being provided in person, but it clearly played an important role. So going forward, we have a lot more work to do to understand how telemedicine is being used now and continues to be used at different points in the pandemic past those early months. But we also want to use this experience where the system basically changed overnight, where these providers who hadn't been using it before pretty much were universally using it. We want to understand what they think about its appropriate role in the future and what that should look like. Post-pandemic, should some patients be able to get all virtual care? Should patients be able to get a televisit, every other visit or once a month, or given the increased convenience for patients and the likelihood that they will stay engaged in treatment if you make it easier for them to get? Should this be used for just certain types of patients and not others, stable patients, for example? So I think we really need to think carefully now that we have this experience about what our system for OUD treatment should look like in the future. And not surprisingly, what we need to do in terms of reimbursement and regulation to support what we think that appropriate role is. And do we need to try to take some of these temporary changes that were put into place and make them permanent? So I'll stop there.
Thank you so much, Professor Huskamp, and thank all 4 of you for these tremendous conversations and elucidating some of the most critical pieces in this moment around health policy. I think you all dovetailed into each other so nicely in terms of highlighting some of the critical aspects. And I think to get back to a point that Dr. Song made about societal costs, I think that's actually one of the most critical things that unifies all 4 of these conversations. And what does it mean at some level to have a societal cost? Are we looking at it from the level of GDP, economic growth slowing, or are we looking at it from many of these other individual factors, whether it's coming from families who are food insecurity, as Professor Bleich was speaking to accessing effective preventive and mental health services, particularly for things like substance use disorders. And then of course, Professor Sommers really speaking about at the highest levels, how can the federal government intervene and ensure that people continue to have access to critical health care? So many important questions that are being brought up during this time. And I know we have a lot of student questions and engagement. So we'd love to go ahead and bring some of our students on now. If we can bring them on in, that would be great.